Hello, good evening. Welcome back to my MVF&x. This is the second event that we are having today, and I'm really happy to be back once again. And this time, talk a little bit about a different topic. Before we talked about egg donation in Greece, and now we will focus on pre-IVF testing. And we will talk about how to understand your results. So we have the best possible expert to discuss this with you. And Dr. Kristýna Frühaufová, you can see her right here. Hello, Dr. Kristýna. Lovely to
Hello.
have you back. I know you've been busy. I know you will be even more busy, but I'm really happy that you found some time and you are here with us today. How are you feeling, and are you ready to discuss our topic today?
Yes, sure, we can go ahead.
Brilliant. Thank you so much. As always, please remember that we will start with the presentation from Dr. Kristýna, but afterwards there will be time for your questions. Please put those in the chat and Dr. Kristýna will answer them for you right after her presentation. Dr. Kristýna is the head physician at Gynem Fertility Clinic in Prague, and I'm really happy to have you back as always. And before starting, we all know that patients always undergo many tests. And of course, we are here to discuss and explain why pre-IVF testing is so important, what's the goal of those tests, and of course, we will be happy to have any questions that you might have, of course, on our topic, okay? And let's go ahead with the presentation and let me know if you can see it, and let's go ahead.
Okay, thanks a lot for the introduction.
Thank you.
So my task today is to walk you through the basic set tests that are needed prior to the IVF treatment. The beginning of the IVF might be a bit confusing for the patients because there's a lot going on. So let me just start with the brief introduction, and hopefully I'll be able to cover all the basic tests that are needed. So why? The first question, why are we testing the patients prior to IVF? Why aren't we just giving all the patients some protocols and just wait what's going to happen? So first of all, we need to find out what medication and what doses of the medication might suit best for the patient, because the optimal response of the IVF is dependent on the dose and also the treatment and let's say the medication plan. Because on one hand, we want to avoid the overstimulation of the patient that would put the patient to the risk, or on the other side of the spectrum, not to have a low response to the stimulation. So we just want the optimal response to gain the optimal number of the eggs. This in the IVF speech means something between 8 to 15 mature oocytes. We also want to make sure that from, let's say, the anatomical point of view, everything is fine and we can proceed on with the transfer, and also to test the female partner for any endocrinological abnormalities, such as, for example, a thyroid dysfunction, just to find out that the body is ready for the implantation and to go on with the pregnancy itself. So let me start with the female testing. We usually start with the hormonal profile. The hormonal profile is done typically at the beginning of the cycle. And what we test is to find out what is the reserve of the ovaries, or like we call it the functional ovarian capacity, which will tell us what is the expected response to the ovarian stimulation. We also incorporate the scan, again, checking for the ovaries, the number of the follicles on the ovaries, and also checking about the uterus itself to see if there are any abnormalities that might stand in the way, such as, for example, polyps or fibroids. And also by doing the scan, we check all the surrounding structures. So we are looking for the signs or indirect signs of endometriosis, for example. We are checking the tubes. So this is like a part of the initial consultation or the initial examination of the female partner. Also, what we do prior to the IVF, that is part also of the legislation of processes, is the test for the sexually transmitted diseases. In the male counterpart, we always carry out the semen analysis. In this case, we are checking different parameters of the semen, such as the count, the overall the concentration, and the overall count of sperm, the motility, and also the morphology. All of those together will give us the idea how the semen quality is like. So, for example, if we know that the quality of the semen is lower, then we might incorporate some methods of pre-selection to find the best sperm, the best swimmers to match the egg. Also, part of the initial consultation is the screening for the sexually transmitted diseases, in women. So when I mentioned the ovarian reserve testing, which mainly is done by the AMH in female, it is a parameter that varies from different age categories. So this graph shows us what is the average AMH in correlation to the age group. We see that actually the AMH peaks around the age of 20 to 25, then it's dropping and is dropping all the way down to zero when the woman reaches menopause. In each category, there are some limits that will tell us whether the AMH is higher, that might suggest the polycystic ovaries, or that the AMH is lower, suggesting that the woman might be experiencing preterm ovarian insufficiency. So again, the AMH will give us the idea what is the possible response of the ovaries to the stimulation. As I mentioned, we are doing the uterus and the tubal assessment. The best tool is the ultrasound. We can add some other methods such as hysteroscopy, which is the, let's say, the direct check of the uterine cavity with a camera, and also some other techniques such as the HICOC that will tell us about the functions of the tube. These are not the first line methods. Only the ultrasound is the first line method, but the others are used in selected patients. For example, when we have a doubt about the function or the presence of some tubal pathology, then those methods can be added in the baseline screening. There are some other tests that, again, might be used in selected cases of patients. For example, the genetic testing. Genetic testing will be incorporated, for example, in women that have experienced several pregnancy losses, or if there's an indication that there might be some genetically related disorder in the family. So in those cases, we start with the genetic consultation and genetic screening, and some other tests such as the immunology, etc., again, in selected patients based on the medical history. So what will all this tell us? The reasons that we gain from combining all those tests, blood work and the ultrasound, will sort of guide us through and help us to pick the right dose for the IVF stimulation and the best treatment plan. It's not black and white, so it doesn't mean that if there is something indicating a pathology, it's completely wrong. It will just tell us that we, for example, need to add some other treatment first before the IVF. And of course, if you don't understand anything or something on the results, please consult it with your physician, because the parameters and the norm is one thing. The other thing is that you have to put it in the context of that particular patient. So after we have done this, let's say, initial examination, then most likely you have a meeting with your IVF specialist to review the results and to set the right treatment, the right plan, medication-wise, timing-wise, etc. And then when the right time comes, when there's the appropriate time to start the ovarian stimulation, then you will start. of course, the patients are generally educated by some other health professionals, such as the nurses, about the application of the medication, but this is like a whole complex process. So what I have to say is that every patient is unique. So as I mentioned, we have to put the results in the context of that particular couple. The pre-IVF testing is both to ensure that you're healthy and you can go on with the IVF treatment itself, and also to choose the best path for us. So thank you for your attention, and I'm ready and happy to answer any of your questions that you will have.
Brilliant. Thank you so much. Of course, we would definitely be able to explore even more tests and discuss it more thoroughly for sure. So thank you for bringing this up. But we will be happy to take any of your questions. So go ahead, type those in. We don't have a question yet, but I'm sure you will have some questions. So don't hesitate. And I would like to ask you before we see any of your questions. So are there any like emerging tests that might help personalize IVF even farther? Something that maybe is not, available, and we are able to already kind of use it, or is it, or something that is still in trials? Let's say anything that you could advise.
Well, of course, there's some like new screening methods, because we don't actually know much about the implantation process. I think that we are still trying to look through the keyhole, and we are not there yet. So there are some new methods, but we have to find out what is the actual application, meaning that some health women that don't have any issues conceiving might have the same kind of issue themselves. So we don't know what is the impact on infertility. So this is something to find out. You don't want to overtreat the patients. You don't want to burden them with too many blood tests, for example, or too many invasive procedures. So it's always about finding the balance, what might be used. And there's a difference in the screening methods that may be applied to the general population, or methods that are only used for selected types of patients. Because the first thing is to get some results. The second thing is to have some kind of suggestion what to do with those. So yeah.
Of course. And with the advancement of AI, are you already kind of using any programs like that can help? Maybe, they are not ready, let's say, yet, but is there anything that you are like right now working at the clinic that might be useful in the future or helpful more?
Well, of course, we've been introduced to several, let's say, several plans, or there are multiple, for example, applications that you can use. Some of them like being focused on also the well-being of the patients, because definitely going through an IVF is not an easy task. So we should be more complex on this. But we are sort of working on cooperating to have, let's say, the full app that would guide the patient through the whole process, like reminding them about the medication, etc., so that it would be like, let's say, the patient to physician diary as well, to have a checklist what is needed. But it takes time to develop such a thing, and also money. Yeah,
Definitely.
but but other than that, as you asked, the AI has been used in the lab techniques quite for some time when it comes to the embryonal development evaluation, for example. But still, the eye of a skilled biologist is superior to those.
All right. Okay. Thank you so much. This is definitely something that we will explore more and more. So we will definitely discuss more about it in the future, I'm sure. So thanks a lot. And, many patients also get confused when their result doesn't seem, perfect, or they are confused that, it's in the normal range, but maybe it's a little bit too low or too high, it definitely happens. What to tell such patient? And of course, also measurement can be different depending on the lab as well,
Yes.
right?
Yes, it's all what I usually am faced with is that, for example, the hormonal profile is not done at the appropriate time, which
Okay.
makes it almost impossible to interpret because since the hormones change throughout the cycle, unless you actually do it at the beginning of the cycle, you just get a nonsense out of it. So then the patients get confused that once their FSH was, let's say, 2, then it's 5. So what? And you do have to know what day of a cycle it has been taken. That's why we need a whole panel. We're using the estradiol level as the control to check, because we know that when the estradiol is low, then you get the baseline results. So if I get the hormonal profile without the estradiol, I can't say anything about it. So this is really tricky about the female fertility. It is easier in men because they are just, the hormonal production is stable throughout any phase of the year. So
Okay.
this might be quite confusing. And as you mentioned, the different lab, different methodology, also the MH itself, it's quite unstable. So what I suggest my patients when they want to repeat the MH testing, just to do it in the same lab.
That way it will be, let's say, constant in a way.
Yes.
Right? Can
And
be.
what I would like also to I know, as I saw that we have some questions upcoming. So just one short, let's say, notice that some of the units might differ in different countries. So, for example, the MH, you always have to know the units because it's actually completely different when you don't know that. So yeah.
Okay, thank you so much. We will go for your question in a minute. There are more coming up, and I would also like to ask you about male fertility testing. Of course, you've mentioned semen analysis result. What about DNA fragmentation? How does it work, and is it something that you recommend on daily basis? How does it work?
We don't suggest it on a daily basis. DNA fragmentation will basically tell us what is the percentage of some improper DNA being present in the sperm. It's only informative tests, so DNA fragmentation cannot be used as a selection method for semen. If the DNA fragmentation is higher, then it might suggest to use some pre-selection prior the ICSI method, prior the ICSI fertilization. So from our point of view, when, for example, you have the normal semen sample and you have a failure in the terms of the fertilization, let's say that on the paper you expect to have the normal IVF outcome, but suddenly it turns out that there might be a semen issue. For example, if there's no fertilization or if there's arrest in the development of the embryos after day 3, which might suggest some semen pathology, then you would investigate further.
Okay, this is how it works. Okay, let's have a look. There are 2 questions here. When you have a very high AMH, as in PCOS, what protocol would you use? And can one adjust the dosage of the medication to reduce the incidence of OHSS? Important question. Thank you.
Yes. AMH and high AMH PCOS, it's always like the tricky part of the IVF stimulation. One other aspect that is not mentioned is the weight of the patient. So we have to adjust the dose according to the weight, because if the patient is, for example, overweight or obese, we have to go for higher doses of the stimulation drugs just because the fatty tissue is diluting the drugs and we need higher doses in natural. But overall, for the PCOS patients, the first choice is the antagonist protocol starting from the second day of the cycle. And sometimes we use so-called step-up protocols, which means that we start on a low dose, check the patient on a regular basis by ultrasound or hormonal profile, whatever is being used in that particular clinic. And according to that, we can adjust the doses.
Right. Okay. Thank you. I do believe it was helpful. Let us know if you have more questions. And next question we have, which diagnostic and therapy do you suggest when I had implantation failure to improve success? Which test can help to find a reason?
Okay, so it doesn't really go with our topic, but I'll be happy to answer that. So implantation failure means that there was one failure of like one embryo, or if there were multiple ones. Usually the definition of the implantation failure is 3 and more transfers of good quality embryos, or 2 euploid embryos and more. So there might be several aspects of the implantation failure. So we do sort of a checklist going looking for the anatomical factors that might play a role. So doing like thorough investigation of the uterus itself, looking for fibroids, polyps, adenomyosis. Also, the hysteroscopy is used to look inside the cavity to see if there's any pathology that might be missed on the ultrasound. Then we look into the environment of the uterus, so the immunology or the microbiome inside the uterine cavity. We search for the signs of chronic inflammation within the myometrium. So basically, this is like the baseline test, but not all of them have to be carried out because again, you have to know the history of the patient and also the genetics of the embryo.
That's for sure. All right. Thank you so much. If you have more questions, go ahead, type those in. And I would like to also ask you, going back to starting a new cycle, how often should the tests that you've mentioned, AMH, FSH, etc., or even thyroid, prolactin, etc., do they have to be repeated?
No, usually we say that they're valid for a year because unless there is an indicator, for example, that the ovarian reserve is dropping by the ultrasound folliculometry, then you don't have to repeat it because then you more or less get the same result.
Yeah. Okay, thank you. And also, this is a question that I'm sure you've received quite a lot, and it's regarding male male partner and female partner. I'm sure you've heard about it thousands of times. So what can I do? So if someone has poor sperm quality, or for example has low ovarian reserve, is there anything I can do? Are there any supplements that can help? How does it work?
Well, again, depending on, I will start with the semen quality, which is a bit easier.
Sure.
Because
Sure.
there's a completely different pathway that the sperm is being created than the eggs, because male partners, they just create the sperm all throughout all their lives, so they don't have a certain capacity, unlike us female in the ovaries. So if there's a poor result, we look at the patient, we look at their lifestyle. For example, if the patient is a smoker, then we suggest to quit smoking. We also look at, let's say, their habits such as the sauna or things like that, which might actually have an adverse impact on the semen quality. So we start with the basic life changes, if possible, like starting a healthier diet, doing some exercises, getting enough sleep, which are usually the ones that work quite well if you do them and if you are able to carry this type of lifestyle changes in. So in the terms of the supplements, it's usually the antioxidants that are suggested. There are lots of supplements that are on the market. The tricky thing is that those are not the actual drugs, not the medication. So you cannot be sure that what is written on the box is actually in the bill and what quality is it. So is something that doesn't have to be measured anyhow. So it's just an off-counter medication that you can buy in the pharmacy. If the semen quality is really poor, then the first suggestion is to refer the patient to andrologist, because in that case, we have to be looking for some other reasons for that, starting from genetics to any anatomical abnormalities, such as varicocele, for example.
Right.
So there are lots of other tests that in those cases have to be done first.
Right.
When in cases of the ovarian insufficiency, there isn't much, unfortunately, to be done in the terms of any changes, any supplements. And again, in young women with lower AMH and preterm ovarian insufficiency, genetic testing should be done and indicated.
Right. Okay. Thank you so much. I know that this is a topic we've many times discussed, but I think it's important to remember and to keep in mind that it's there are some options that we can do, but there are some things that we cannot, let's say, overcome. That's the reality. Thank you so much. And one more question we did receive in sorry. How would you manage a male partner that has tested positive for hepatitis B virus during pre-IVF testing? All right. Another question.
Yes.
Yeah.
That's a quite important question, because that does happen sometime, depending whether the hepatitis B is active or not. So if the hepatitis B is active, in that case, we have to start treatment of the male partner first. If it's due to previous hepatitis B infection, which is quite common in some parts of the world, then there's no need to stop the treatment. We can just carry on with the normal IVF course. Usually at our clinic, we ask the patients to sign waivers saying that we found this result that is not negative. And if the woman is negative for the hepatitis B, there is a very low potential risk of transferring the infection throughout the embryo, but I am not aware that this has actually been ever described in literature. And if the embryos are stored, we store them in a like separate container. That's basically it.
Okay. Thank you so much for explaining. I hope that was useful. Let me know if you have more questions. If not, we will be finishing for today, but I think it was very informative already. And of course, if you wish to ask more questions, remember that you can get in touch with Dr. Kristýna and her team at Gynem Clinic, and I'm sure they will be happy to help you out. And as always, they always need more details from you to give you a proper answer. This is always the case. So let me know. If not, we will be finishing for today. So, Dr. Kristýna, thank you so much for today. Any final piece of advice before we finish for today?
Well, I think that the most important message for me is, if you do have any questions, doubts, instead of Googling it, just ask your physician, because the IVF treatment, as I said, it's quite demanding from all the sides that are involved in the IVF treatment. And the most important part is the trust in between the patient and the physician, because we are dealing with a very intimate topic. So, yeah.
That sounds good. Thank you so much for that. And as I mentioned, we will be finishing for today, but stay tuned. There are more events coming up, and we will be back with Dr. Kristýna Frühaufová as well very soon. So stay tuned. You can go to myivfn's.com website and you will find all of our upcoming events. We still have plenty to come till the end of the year. So don't hesitate. It's all anonymous, so we are always happy to help you out. Thank you so much, everyone. Have a lovely evening. Dr. Kristýna, thank you so much as always, and speak to you soon. Take care, everyone. Bye.
Have a nice day. Bye-bye.